broadcasting.
Great.
And recording. So very exciting. Let's see how many people we've had. So 97 people added it to their agenda. And usually I think about half of those actually join in person because I think they're working or they're somewhere else in the world where the timing isn't quite right. So we'll see how many people join us today.
Okay.
One already. Hello, welcome. We'll get started in a few minutes. It is fun watching people join. I see Dominga has joined us on the
Yes, just so I can stay in touch with everybody in the chat.
Awesome.
So you will let me know when I should turn off my video.
Yes, I will say it out loud, and if you miss it, I can turn off your video as well. So
Perfect.
No stress. So hello everybody, welcome. We'll get started in a couple minutes. It's about 3 minutes to the hour.
And those of you who are joining us already, please share with us where you're joining us from in the chat. That's my favorite part of seeing where everyone's from and seeing that we're broadcasting to everyone all over the world. It's amazing.
It really is. I've had a lot of fun seeing where everybody's joining from, for sure. I'm trying to remember, we had someone that has been joining us from Ecuador. I've seen people from Canada. I saw one person, I think she's in Israel.
Singapore, we had a few people from Singapore last night. It was incredible.
Oh, you should do a map of it.
I know, I think we have one.
Yeah, for the whole conference and kind of publish it.
Spoiler alert. Hello, Dominic. Hey, Bridget, Jan, Maria. Thank you for joining us.
So it was in the plan then, Katie.
Yeah. We have one. It's really cool. It's amazing how far and wide this has spread. Very wonderful. So we'll get started in about 2 more minutes. And in case you're just joining us and you missed us a minute ago, if you want to tell us in the chat where you are joining from, that's where we are. That's what we're talking about right now, is just how incredible this is that people have joined us from all across the world, and we'd love to hear where you're joining us from.
I mean, it's great. Even your presenters and are all joining from all across the globe. Katie, you're joining us from Florida. I'm joining you from Missouri.
And Leema is on.
You're on mute.
Sorry, and I'm from London.
Very cool.
Absolutely amazing.
We are everywhere. So we have 9 people with us right now. I'll give them another minute and then we'll get started. And some people, I think, join a couple minutes after the hour. So it's been fun to watch, for sure. Very cool. I feel like I need like a stopwatch with like the seconds counting down. So I keep looking at it and it still says 11:59. Okay, there we go. So now we are at noon Eastern time. Thank you everybody for joining us. If you don't know me already, my name is Katie Wright. I'm the director of the VEDS movement, a division of the Marfan Foundation. And I also have Dominga No with us today from the Marfan Foundation.
Hi there.
Yes, say hello. And she will be managing the chat box in the Whova app. So if you're just joining us, look out for Dominga in the Whova app. It's been really amazing connecting with everybody there. We're really excited to welcome you to the third week of the International E3 Summit, Educating, Empowering, and Enriching Our Community. This is brought to you by the Marfan Foundation and its divisions, the Loeys-Dietz Syndrome Foundation and the VEDS movement, and our partners in Europe at the CERN. We are making history together in these 3 weeks of the International E3 Summit. We have, as of today, 2,800 registrants from 72 countries across the world, which is truly incredible. And we hope that you've been able to connect with people in the Whova app everywhere. And we know and hope that those will be lasting connections for you. We'd also like to thank our presenting sponsors, Brigham and Women's Hospital and American Communications Construction, for helping us bring this E3 Summit to you. And we want to let you know before we get started that the International E3 Summit is a forum to provide an open discussion of issues related to genetic, aortic, and vascular conditions. Opinions stated in each of the talks are those of the speakers and not necessarily those of the Marfan Foundation or the CERN. So if at any time you have questions or need clarification about a difference in opinion that you hear between session speakers, feel free to contact us at marfan.org/E3ask. That will get you to our Help and Resource Center. And just keep in mind that we do have a high volume of questions coming in right now. So it might take a little bit longer than usual to get back to you, but we will get back to you as soon as we can. If you'd like, after this, we would really appreciate if you could provide your feedback on this session by accessing this little rate button right here that's in your session survey. That will let us know how you enjoyed this session and what you learned from it. We also opened an E3 Summit survey at marfan.org/E3 survey, and we really would love for you to submit that survey and let us know how you felt about this entire International E3 Summit. And in appreciation of you doing that, we are selecting 3 submissions at random to win a $50 US dollar prepaid international debit card. Surveys to be eligible for the drawing must be submitted by 11 p.m. Eastern on September 16th. Before we go into the presentation, we do have Dr. Leema Robert with us today, who prepared the presentation, and I do want to give her an opportunity to say hello before we get started.
Hi, everyone. So I'm Leema Robert. I'm a genetic consultant and I work in London. I have been leading the MSA working group on VASN, specifically vascular EDS, which is one of the reasons why I have a particular interest in the topic today.
Thank you so much, Dr. Robert. And now myself and Dominga and Dr. Robert will put ourselves on mute and take off our videos so that we can play the presentation that Dr. Robert prepared, and then we will be back for a Q&A. So if at any time during this presentation you do have questions, there's a Q&A box in your Whova app, and we encourage you to submit questions there. We will have plenty of time for Q&A in this session, and I will be reading questions from the Q&A box for Dr. Robert. Thank you.
Hi, my name is Dr. Leema Robert. I have been given the topic of discussing pre-implantation genetic diagnosis and vascular EDS. So I will start off with just a little brief overview of vascular EDS, which I assume most of you are familiar with. Vascular Ehlers-Danlos syndrome is rare, 1 in 200 to 1 in 50,000 is the estimated prevalence. It's a genetic condition that typically affects young individuals. And mutations are noted in people with collagen 3 gene. There are several types of mutations which also affect the severity of the condition and the presentation as well. People with haploinsufficiency mutations tend to have a milder phenotype when compared to people with glycine substitutions and splice site mutations. So moving on, the main topic today is talking about pregnancy and options available for reproduction in patients with vascular EDS. So the question I think often that's asked is, are there any risks associated with pregnancy in vascular EDS? The ESC guidelines, which were published around 2 years ago in 2018, says that there are severe vascular complications that can be associated with vascular EDS. So as they advise that caution needs to be used in counseling patients with this condition for pregnancy, and that this needs to be an individualized plan in most cases. So there was a bit of controversy with the ESC guidelines because the advice in the recommendation said high risk pregnancy not advised, but clarification in other parts of the same document do say that it should be a shared decision-making process when contemplating pregnancy in this condition. So where is this data coming from? I've used data from the UK. We've got the Embrace UK database, which says that which documents all the maternal cause of death in the UK. And one of the things that has been highlighted is around 8 to 9%, which varies year on year, is associated with iotopathy, and this causes morbidity and mortality in patients with who are pregnant with an underlying condition. So if we take that as one end of the category, because this includes all patients with iotopathy and does not include vascular EDS as such, and move on to vascular EDS specifically, there was a paper that was published in 2014 by the USA group, Murray and Pepin, and it highlights very clearly that pregnancy-related death in women was estimated to be around 5%. They had 30 deaths in 256 women. And as I've outlined in the red box below, there were 4 significant arterial complications which led to the death in these individuals. If we use this 5% as the minimal criteria, the other paper that we also usually discuss when we're talking about pregnancy is the French group publication in 2015 by Frank et al., where they report that obstetric complication was sometimes the first presenting sign in some patients with vascular EDS. And they also outline that the type of mutation impacts the outcome in pregnancy as well. In their cohort, however, no maternal deaths were reported. So what can we conclude? Pregnancy is associated with significant obstetric complications. Arterial rupture seems to be the main cause of maternal death in vascular EDS. Arterial morbidity seems to be linked with the presence of abdominal lesions, and therefore imaging prior to considering pregnancy would actually be really important. Maternal age is a prognostic factor, and the type of mutation also impacts on the outcome. So from this, I think it is important for us to take into account that these points need to be considered and discussed with the person affected so that we can make informed decisions as to what is appropriate for them. So the next thing being, one of the things that usually patients ask me in clinic, so what are the reproductive options that are available for patients with vascular EDS? We have a specialized setup in our hospital called Pre-Pregnancy Counseling Clinic, and this is discussed usually in those clinics. It's a multidisciplinary team with geneticists, cardiologists, and obstetricians. The main part of this clinic would be discussing reproductive options, which would perhaps start from natural pregnancy, what the risks are for having a child who's affected, whether prenatal diagnosis would be an option, which would be invasive, like CVS or amniocentesis, and then considering termination of pregnancy if affected, pre-implantation genetic diagnosis, sometimes even adoption, sometimes surrogacy, And obviously, we have to keep in mind that doing nothing is also an option, and that will also be discussed. Maternal health, what medications the mother is on, and the fitness to bear a pregnancy will also be evaluated in these clinics. And following all of these evaluations, an individualized plan is made for follow-up during pregnancy, which also includes monitoring of the fetus. So I've just added a couple of cases here, and I'm not going to read through all of them, but these are the cases that we usually, type of cases that we usually encounter in our clinics. It will be something as simple as a young woman who's affected, who does not have any major complications, but has been maintained on treatment, and how will you counsel and advise this person? Or somebody who's had complications in the past, and wants to have another child who's unaffected. And again, how would you counsel and advise? So I thought I'd briefly touch upon what PGD is for people who don't know about this process. PGD, as in pre-implantation genetic diagnosis, is a treatment which involves checking the genes of your embryo for a specific genetic condition. And in this, it would be vascular EDS. The embryos which have been tested and are free or do not have the misprint that is known in the affected member in the family will then be placed back into your womb to hopefully continue to develop and achieve a pregnancy. If this is done as self-funding in UK, it is around £12,000 per cycle, so it's not a cheap process, it's quite expensive. So timeline, which is again another issue because it's not something that we can do within a month or two. As you can see in the right-hand corner, it takes around 10 to 15 months for this whole process. So usually you get a referral, you seek a license application for approval from the HFEA, and then we go through the process of sample collecting and your fertility cycle, and then your egg testing, as well as embryo transfer. I'll discuss in a little bit more detail in the next couple of slides. So people who undergo PGD need to go through an IVF cycle to create embryos. So you would have to have ovarian stimulation. I apologize for the slight jumbling of my slide there. And you have to go through egg collection and then fertilization with ICSI. This process usually takes around 3 weeks. Moving on, after that, the embryos are developed in a dish, and when they reach the 5 to 6 day stage of a blastocyst, they are then biopsied. So a single cell from this blastocyst is actually extracted for genetic testing. The process of genetic testing is now called pre-implantation genetic haplotyping. So we are looking at which is the likely affected allele and trying to trace that in the embryo. And as you can see, a man and a woman with different alleles can have different options. The option of what we really want for this couple is a non-carrier or a carrier in recessive conditions where they do not actually have any problems. But for us, in vascular EDS, knowing that it's a dominant condition, we would actually want a non-carrier a non-carrier embryo for implantation. So after we identify that, depending upon the number of embryos that are available, the best embryo is chosen. The womb lining preparation medications are given to the woman, and then embryo transfer happens, and hopefully a few weeks later, a pregnancy is achieved. And this process takes around 7 to 8 weeks. So pros and cons of PGD. I think need for avoiding termination of pregnancy is probably one of the topmost pros for most patients. It avoids repeated high-risk pregnancy and invasive procedures in pregnancy as well. In the UK, it is funded depending upon some criteria for and the patients are fully eligible for 3 cycles. But if it is not funded, it's quite complex a procedure with cost of around 12,000 pounds per cycle needed. The success rate, however, is not high. It's a third, and therefore people may have to have several cycles before they achieve a pregnancy. So then coming on to the next thing, is IVF safe in vascular EDS? That's the next question to ask, because we are giving drugs to these women for stimulation of their ovaries to produce enough eggs so that embryos can be achieved. There's not much literature on this, but there are a couple of papers I wanted to highlight here. Germain et al. In 2007 hypothesized that increased serum estradiol levels were associated with increased vascularity throughout pregnancy, and this may be the reason why vascular rupture in pregnant women occurred, specifically during the 3rd trimester or in the postpartum period. Similarly, Bergeron et al. In 2014 therefore hypothesized that if there are high estrogen levels in pregnancy, this might be the underlying mechanism for vascular fragility and the thinning of the aneurysmal wall. In vascular EDS, however, not always do we see an aortic or vascular dilatation, but there is increased vascular fragility. Therefore, ovarian stimulation may itself carry risks for patients with vascular EDS. There's this interesting paper by Bergeron et al. In 2014 where they describe a 33-year-old female with vascular EDS who had multiple arterial dissections and also had a ruptured aneurysm of the splenic artery. She went through an ICSI cycle. They avoided IVF and used this new procedure called IVM, which is an assisted reproductive technology which involves collecting eggs from a woman before they are matured without use of ovarian stimulatory drugs. Using that, PGD and surrogacy was facilitated for this case, but the embryo did not implant, and therefore it was not a successful pregnancy. However, this lady did have the splenic artery aneurysm which ruptured and therefore had a complication, and so further cycles were not undertaken. So what can we conclude? Ovarian stimulation therefore might increase the risk of arterial dissections. More studies are required because there are very few papers on this. And IVM with PGD and surrogacy might be possible, but again, there's a high failure rate. Therefore, more studies are required to validate the success of this procedure. So recommendations. Care in a multidisciplinarily specialized unit with shared decision-making is really important. Pre-pregnancy counseling of these patients in dedicated clinics, specialist clinics, as I've described previously, would perhaps be ideal for them. Discussing reproductive options, including limitations of pre-implantation genetic diagnosis, would be appropriate. Prior imaging of the whole arterial tree to help manage make plans and manage pregnancy is really important. And most importantly, continuation of medical therapy and monitoring of fetal growth would also be recommended. So with that, I will end this session, and I'm happy to take questions.
Thank you so much, Dr. Robert, for preparing that presentation. And if anybody has questions, we are now entering a Q&A. So I will be pulling up questions in the Q&A, and Dr. Robert is with us as well. So our first question, Dr. Robert, is for someone who's had a child who has 2 copies of a mutation leading to VEDS, one which is de novo and the other one which is inherited. If that person becomes pregnant again, can a pre-implantation diagnosis help them to have a baby with no VEDS mutation?
So it depends on whether the woman's affected or the man's affected. That's the main thing to clarify. So a de novo mutation in the child means that's something that we probably don't have to worry about because it's happened for the first time in the child. And it's unlikely to affect, the risk of this affecting other children would actually be very low. So there is one parent who's affected, so this would be a 50-50 risk for another child being affected in a similar manner, in which case, yes, PGD is possible. It's just that when PGD is offered to the woman who's affected, we have to take into account all the additional things that I've outlined in my presentation. If it's the male partner, then the risk is probably much less. And surrogacy can also be something that actually can be taken into account because most people prefer to have a biological child, but are happy for surrogacy to avoid the complications of carrying a pregnancy.
Thank you. And I hope that that answered their question. We do have a question here from someone with Marfan Syndrome, and I think you're okay to answer those ones.
Yes, I'm fine, yeah.
Great. Okay, so if someone is inseminated after IVF, what are the issues to look out for during pregnancy for a Marfan patient with dural or sacral dural ectasia? Could this have an effect on the mother and the pregnancy?
So keeping in mind that it's a process that you go through, if the IVF process, apart from the ovarian hyperstimulation, does not cause any major problems to a pregnant woman or to a woman who's undergoing through that whole process. We have taken several women with Marfan syndrome through pregnancy, as long as their aortas are okay and do not need immediate attention. Their medication is also adjusted so that it doesn't cause any problems with fetal growth, but they are maintained on medication as well. So we don't anticipate any major problems, but with dural ectasia, back pain may be worse because all your joints are actually a little bit more flexible during pregnancy anyway, which might actually cause more issues with patients who have connective tissue disorders. So we don't prepare for anything specific apart from what we would say is normal follow-up for them, which will be more frequent than any other pregnant woman anyway. And we'll be monitoring their aorta more frequently as well. And fetal growth, especially if they are on beta blockers, but otherwise nothing major will change. Because of the dural ectasia, during labor, for example, anesthesia and all of those considerations will be taken into account as well. So it's a wide range of things, and perhaps this person needs to seek a proper opinion so that it can be individualized for them.
Okay, thank you so much for answering that. And we've got some great questions coming in. So our next question is, you've talked a little bit about the risk possibly arising from estrogen and IVF for someone with vascular Ehlers-Danlos. Is that same risk present for somebody with Marfan syndrome? Meaning, can the increase of estrogen cause a dissection in a patient with Marfan?
So not something that's been reported. So you're talking about the hyperstimulation or as an ovarian stimulation, not something that's been reported for Marfan syndrome. As I said previously, we have taken several women with Marfan syndrome through pre-implantation genetic diagnosis. Although we do monitor them carefully, we haven't had any reports of similar problems. And that is from my experience. This is one of the reasons why Jolene Rose Heslink is actually collecting data via the ROPAC study. We are also considering with both Dr. Bart Loys and Melissa Lees in the US to actually collect data on patients with vascular EDS, Loys Dietz, and Marfan syndrome. But for their retrospective pregnancies, so pregnancies that people have had in the past, so that we can get the data together and see if anything further comes out from this.
Okay, thank you. The next question is about the success rate of pre-implantation. they're asking if that 1/3 success rate that you mentioned for pre-implantation applies to using a surrogate as well.
Yes, is the answer. But surrogates, I think the complications with surrogacy is more in finding a suitable surrogate, and that is more expensive, and often that cost is also borne by the couple, not properly funded. And when the surrogate is chosen, often it will be a person who is fit to carry a pregnancy, so there's no additional risks there. And once you reach the embryo transfer stage, the third, the success rate remains the same.
Okay. And that is the end of the questions that have come in, but I think I will ask another question just to give more people time to submit questions if they have them. Yeah. So we're talking about, IVF and all of these things to help somebody get pregnant safely and have a child that does not have one of these genetic conditions. For someone who is considering, I think I've seen things like egg donations and things like that you can do. Are patients with VEDS or Marfan or any of the other connective tissue disorders, are they eligible for that, or is that more risky for them?
So are you asking whether you will do egg donation, or are you asking if you can have an egg for donation?
If you can give an egg for donation and go through.
Egg donation again involves stimulation of your ovaries for egg collection. That's the main thing that we are worried about in vascular EDS. So there is a slightly increased risk of arterial complications. Therefore, you giving eggs would probably not be advisable because there is a risk for you. Secondly, egg donation is often taken from individuals who do not have an underlying genetic condition. And the fact that the woman already has vascular EDS increases the risk of that being transmitted, and therefore perhaps again not advisable.
So for someone who is not diagnosed yet with one of these conditions who decides to go through this, do they test the eggs before giving?
No. So we have several other genetic conditions. I won't say I have experience with vascular EDS, but other general genetic conditions that we actually come across. The donor often is not tested. The family history is assessed to make sure that there is nothing significant. And what is in most IVF centers, they actually have the option of donors coming back with more medical information if they are diagnosed, so that children born from the donor sample being used, or the donor egg or sperm being used, can be informed and appropriately counseled for it.
Great. So let's see. Oh, here's some. Actually, I think we still do not have any other questions. So I think from here on, if there's anything else that you would like to talk about or mention, or common questions that you received from people that weren't asked today, do you have any of those that you could share with us?
So I think one of the major things that I'm not sure that people have taken on from today is to make sure that the imaging, as in people who have abdominal arterial regions, are actually at much more higher risk when compared to individuals who do not have any abdominal lesions from before. So I think really I would say specifically not to consider just vascular EDS as the condition, but actually look at all the subcategories to see what their risk is. And that should be something that each individual should seek medical opinion for before they're considering pregnancy. And I think I would emphasize that a lot. Most often I actually get referrals where it says there are a couple interested in PGD, but I don't get the information with regards to their imaging or what medication they're on. And often have to chase all of this before I can even make up my mind as to whether they're eligible for PGD or not. Okay. The other thing that we often actually highlight is, additional risk like smoking is not great. We also choose women who are less than 39 because the fertility is, not fertility, the implantation and success of the pregnancy is actually decreased the older you are. So we have a cutoff of 39, a BMI cutoff as well, and including smoking as well.
Is that a low BMI cutoff or a high BMI cutoff?
Low so you have to be in the normal BMI range. If you are higher, then your chance of achieving a pregnancy is actually much lower, and it's similar for low BMI as well.
Okay. We did have a couple other questions come in while we were discussing this. So I think earlier in the presentation you mentioned very briefly mutation types playing a factor here. And could you elaborate on that? This person is very amazed when women carry normal pregnancies without knowing that they have VEDS. How common is that?
So I have a large family where I'm, a proper glycine substitution, but each of the women that I know in the family have had 3 or 4 pregnancies with no major complications. It's always surprising to me that that family actually has not had that many complications that I worry about in other individuals. So I think there is a variability. You can never say that all people with the glycine substitution are going to have significant complications. And obviously the family background genetics actually plays a part there as well. And that I would definitely take into consideration in my counseling. In terms of the haploinsufficiency mutations, we do know that haploinsufficiency ones actually have a milder phenotype, probably present more in their 40s rather than in their 20s, as we would expect with glycine substitutions or splice site mutations. So the same thing actually applies in terms of pregnancy as well. The risk of pregnancy-related complications for them is much lower. So we would not say, quote that 5% risk for them. We'll probably say it's much less in you. But we can't give a definite answer because we don't have enough data to actually give a number.
Okay. Thank you. And do you know of locations in the United States that do pre-implantation?
So United States, I don't, but I know of all the places in the UK. So we are the National Referring Centre for PGD in our hospital in London. There's one more private hospital in London that does PGD. And Europe, I know several centers, but US, sorry, I am not that familiar with all the centers there.
Okay, so for whoever asked that question, please submit that to our Help and Resource Center at marfan.org/E3ask, and that will get you into our Help and Resource Center, and we can help you find a center, hopefully in the United States, that can help you with that. I'm sure that they exist. I would be surprised if they did not exist here, and we will do our best to get you connected with where you need to be. So that is the last of our questions. We'll just give it another 20 seconds just in case anybody does have any last burning questions here. Now is your time to submit them using the Q&A feature. And we got one. So my VEDS daughter is 10 to 15 years away from needing to consider this. Where do you see progress leading us in the next 10 years?
That's a tough question because sometimes the progress is actually quite significant in some genetic disorders. I think we should probably, my personal feeling is that medical therapies might actually make a difference, and which is what we are looking at in terms of clinical trials. To see whether celiprolol we use very frequently in the UK and Europe, but it's not something that you use in the US. We're also considering there's a trial happening with a French group with losartan, and we are also considering whether something similar for other groups within VASAN would actually be helpful to collect data as well. So I think clinical trials and medical therapy will probably change things in terms of complications for patients with vascular EDS. There's a paper from 2019 or 18, I can't remember exactly, from Frank et al., where patients who have been on celiprolol for several years seem to show less complications when compared to people who have not been on celiprolol. Although the comparison can't be taken exactly in that way because it's a natural history study. So that's where I think the focus will be. So in 10 to 15 years, if we reach good medical therapies for patients with vascular EDS, then the complications are likely to be less.
So this has the opportunity to change drastically in the next 10 to 15 years, depending on that treatment.
Yeah, on the outcomes of these studies, yeah.
Okay. Great. And the next question, for someone considering starting the PGD or IVF process, what are their starting steps? Do they need a genetic consultation, or is it another expert that they should be seeing?
So the starting steps, obviously you would have a genetic consultation to have your diagnosis, your consultation with a cardiologist to see what your imaging looks like, as in, where in your arterial tree you're affected. You'll also be started on treatment. All of those things comes first. Once that happens and you are ready and considering a pregnancy, then you will be obviously referred on for a further genetic counseling session to discuss your reproductive options so that you can actually choose what's right for you as a couple. Then referral onto the PGD center.
Okay.
So again, there's probably another 6 to 7 months delay there. Keeping in mind the whole cycle itself can take up to 2 years.
Okay. And I see someone has raised their hand and unraised it. So if you raised your hand and you had a question, please submit it in the Q&A. I can't do anything with the raised hands, but I suggest that you put your question in the Q&A. And right now I don't see any additional questions in there. So we'll give it another 10 seconds and see if that one comes in. But otherwise, we've reached the end of the Q&A. And this is where elevator music would be helpful.
Well, thank you everyone for having me. That's perhaps the best way of ending it.
Yeah, and oh, we've got one more. I'm sorry.
Okay. Yeah.
This is the most most exciting Q&A that we've been up at the end of the Q&A and then back several times. So it's great that people are having questions and submitting them. Thank you so much. Are you familiar with Stickler syndrome? And
Yes.
so, okay, so this person, their son has Stickler and his risk is not really at question. Is the timeline shorter in that case for somebody who is not high risk?
No, it is very similar. So the whole PGD process is exactly the same because with Stickler syndrome, it's likely that the license application has already been done. So that might be slightly shorter because there might be someone with the condition because it's a bit more common than vascular EDS, although it is a rare condition, if you understand what I mean.
Yeah.
So it's likely that the license already exists, so that could be shortened a little bit. But otherwise, the timelines are not very different.
Okay, thank you. And that is our last question. So I would have a couple things to share with you before we leave today. I do want to make sure you know that if your question was not answered, please submit them to marfan.org/E3ask for our help center, and that will get your question in queue for our Help and Resource Center, which is receiving a lot of questions right now. We also encourage you to complete the session survey in the Whova app for this session specifically, and the E3 Summit survey that we mentioned earlier. That's at marfan.org/E3 survey. You can use the Whova app to connect with community and visit the exhibitors in the virtual exhibit hall. And we're hoping that this Whova app allows you to connect with people everywhere with conditions similar to yours and help you feel connected with this broader community. We hope that you enjoyed this, and we would love to see what you learned if you want to share on social media using the hashtag E3Summit20. And if you'd like to help us make more programming possible, you can do so at marfan.org/donate. And I would like to thank Dr. Robert again for providing your expertise and time for this community. I think it's really valuable, and thank you so much for doing that.
And thank you for having me. And as I said, we are trying to contact patient organizations for participation in our study looking at retrospective pregnancies that people have had, as in past pregnancies. So hopefully when that is available, it would be great if more people could participate.
Thank you. And if you would like to connect for more information about that, please feel free to connect with us in our Help Center, and we will help you get connected with that. Coming up just in about a week is our Aortic Disease Awareness Week, powered by the Marfan Foundation, September 19th to 26th. And we hope to see you join us in raising your hands for raising awareness of the risk factors for aortic disease. You can find more information on the website at marfan.org and on social media, or by connecting with us, and we hope to see you participate. Thank you so much, everybody, for joining us, and have a great rest of your day, afternoon, or evening, wherever you are.
Thank you.
Thank you.